So we just wanted to just recap on the difference between end of life and palliative care, because we've put them together, which I think is absolutely right to do for this presentation. But when we're talking about end of care, we are thinking about when the person is nearing the end of their life. As Alex has said, it's very, very difficult to actually be able to specify when that is. But quite often you see this is a time when the person with Huntington's disease is sleeping more, eating less, drinking less, and you're starting to see that change, that's very slow day-to-day change in their presentation. Although Alex and I were talking about this morning about our presentation, and we've both been in situations where we've thought as a team, as clinicians, that someone is nearing the end of their life. I've certainly worked in care home settings where we've informed family, and family have come in and the person's bounced back. So we don't always get it right. Can be difficult to determine, but generally we talk about end of life care when someone's nearing the end of their life. And then palliative care, as Alex has said, is we talk about this before someone becomes to their end of life. The principles of palliative care are for when we're dealing with a condition such as Huntington's disease, where there's no active cure or treatment for the illness. So we tend to focus on the change and optimizing quality of life for the person and the family. And it's more about thinking about the symptom management and pain relief. And as we've already touched on, Alex has touched on, is having these conversations really early on, and actually having the conversations with the person and the family while the person still has capacity to make decisions about what they would like when they become close to the end of their life. And that's a photograph of the founder of the hospice. Was it hospice? I've gone
hospice
blank
movement.
now.
Yeah,
hospice movement. Yeah.
Dame Saunders. So she recognised that there was this sort of middle ground, if you like, where these things needed to happen. And so she founded the hospice movement. So it's not just us being sort of very sort of typical going, gosh, here is, this is when palliative care happens in old age. This just happens to be a photograph of this lady working in a hospice setting. I think it's quite important at this point to actually say sometimes we talk about advanced care planning when people have lost the capacity or the communication to be able to express their wishes and feelings, which is why we often talk to family about what would they have wanted, what were not necessarily their wishes for end of life, but what would they have wanted, what were their values. In other words, talking about this gentleman earlier on, I said that he had lost the ability to kind of communicate his wishes about end of life even prior to me meeting him, but his family knew what his values were, and collectively we discussed them. So, and I think people get worried about saying, well, this is what I think he would like, because it wasn't exact, because that person's already lost that ability. What we're just trying to do is ascertain what they were like as a person and who they are still as a person. And it's our, if you like, it's our best guess for what they would want. But you won't be held to it. I think that's the other thing that worries families and worries less experienced professionals. You won't kind of be held to it. It's important that you just try and have the conversation and feel your way.
Yeah.
Right.
Okay. So occupational therapy, care in palliative and end stage for Huntington's disease can be complex and challenging. I think we've probably, throughout our series, have talked about how complex and challenging a patient group it is to work with as an occupational therapist, but particularly when we're starting looking at palliative and end care stage. So the OT intervention will be dependent on the stage of someone's journey in their HD, but also where they physically are living. But we also have to consider the skills of the individual therapist as well, and what experience they've got working with people with Huntington's disease. So if we think about, we might have an occupational therapist working in a hospice who is promoting quality of life at the end, and coordinating care and working with the families. But her or his role as an OT could be very different to an OT working in a neuro community service, for example, like Alex, who's working hard at keeping people at home. We've got OTs working in care homes, OTs working in housing and equipment services. So over the progression of someone's HD, an OT is going to be involved. But at this stage of palliative and end stage, we're really looking at promoting quality of life. And we're key in having discussions with the person with Huntington's disease, but also with the family about what's important to them and what care is going to look like. We can be heavily involved in coordinating care with health professionals. So quite often that link between the care agencies going in, with the GP, with the speech and language therapist, for example, signposting and referring. It's really important as OTs that we have understanding of advanced care planning, and potentially being involved in that as well. And as Alex has said, advanced care planning includes a number of documents. So your advanced statement would sit in there, which is about you planning and talking about what you would like your care to look like, as your care now and care in the future, but also as you're becoming close to death and after you've died, what you'd like to happen as well. Within advanced care planning, we've got your advanced decision to refuse treatment. So that's the legal documents, where you can make decisions about what you want as your disease progresses, and also the decisions you make there will be upheld if you no longer have capacity. And Kath Lyons, who we've referenced at the end, has done a really good presentation on advanced care planning, and she talks about capacity, and she also talks about communication, and using yes and no as a way of communicating your needs. The other role for occupational therapist could be looking at provision of equipment, but also training for family members and training for care staff. And I haven't put that on there, but following the changes, we can put equipment in and it can work for a short period of time, and then something changes. So it's going back and reassessing.
Just because we are coming to palliative end of life stages doesn't mean that dynamic assessment that we spoke about previously doesn't stop, because again, you can have folk who are having really fighty days and people that are having really lethargic days all in one. So that's important again to consider. Still embed that into your work. And
then promoting and maintaining dignity for the person with Huntington's disease. So as Alex said again, the more that we know, the more information we have on someone, if they're not able to communicate that, their values, their wishes, their beliefs, that helps us as healthcare professionals follow their wishes. It takes away the guessing for us, and I guess that's the same for families as well. If we've had these difficult discussions, then we don't carry the burden of have we got it right? Are we doing what's best for the person? I think we then go on to OT process. Yes. So although we've still put early discussions there, although we're talking about palliative care and end of life now, early discussions about what someone's wishes are is really important. But I guess we also need to remember that choices change. Just because if someone has made a decision about what they'd want in the future, that doesn't mean that decision stands later on. But it helps us, I guess. For me, I've worked primarily with people late stage, palliative and end of life, and I've been in MDT meetings where we've not had information about someone in terms of what their end of life wishes are going to be. So I know I've worked with people who are losing weight, their swallow is affected, recurrent chest infections, going in and out of hospital because of infections, and us having a conversation about, is PEG the right decision for this person? And not having any information about what their wishes would have been, then we're having to make that decision as a team. And that feels like, to me, that's a really big decision to be making. I mean, it's great that you're having that with the team, but we start thinking about someone's quality of life as it is now. So to have that documented can be really helpful. I was talking to Alex about a young lady that I worked with who perhaps didn't have capacity to make the decision about having a PEG, but was able to give her views by screaming and shouting when I spoke to her, I don't want it, I don't want it. And that was valuable information for the team, that actually she really strongly didn't want to have a PEG, although we weren't able to go through the full capacity assessment with her because it was distressing for her. But it was important to still have that conversation, and I knew it was going to be distressing, and we don't want to distress people we work with, but also it was important to know what her views were, and it gave us a flavour for what she wanted. So the OT process, so early discussions if we can, but we have to understand that not everyone is going to want to have discussions, and there's no right or wrong about that. As Alex said, some families, some people will say that becomes a burden, and I guess we have to consider about who's having these discussions. Is it the occupational therapist, or is it someone else in the team? And that we are liaising with other members of our team, so we're not bombarding people. These are really could be really challenging conversations, and I wouldn't expect every member of the team to be going and having them either. And as Alex said, it doesn't matter which person in the team ultimately either. Assessment, so as OTs we'd be looking at physical presentation of someone, so function. So one of the questions Alex has gone over was about swallowing, wasn't it? We had a question about what's your opinion on offering food and fluid at the end of life? So as an OT, I would be looking at not the safe swallow and holding the food in the mouth, because that's the role of the speech language therapist, but I would be thinking about, can a person hold the cup or hold the straw, or how are we using a spoon to help feed someone? So I'm looking at physically how the food, the drink is getting to someone's mouth, and the posture, how to maintain someone's posture, be it in sitting or being in bed. Head, controlling someone's head can be really difficult at the late stages. So actually I'm not only looking at the person when I talk about physical function, but I'm thinking about carers, and I've certainly advised on carers and how to physically help hold someone's head, to support head while being given food and drink. And I'm thinking about the posture of the staff and how I want the staff to sit, and bringing in perching stools, for example. So at this point, yes, the person with HD is at the fundamental part of our assessment, but we have to think about the environment, and within the environment, the family and staff. So assessment, physical, social, environment. So in the environment, looking at what equipment's required, looking at the setup of the equipment for the person and family members or carers. What is the social, I would think about what's the social setup. So I mean, Alex, that's more for you, for the community, but even in a care home situation, you know, family coming in, children coming in, and actually being aware. I've worked on wards where residents are coming to the end of their life and the impact it has on other people within the unit, you know, other members of their social community, I guess. So that's what I would be considering. That's going to be different in the community, Alex, as an OT working in the community for social assessment of the social side, the family members. But thinking about someone's psychological needs, emotional needs, spiritual as well at the end of life. It's really important that we consider and bring what they would like, what end of life looks like for them. Financial I've put down as part of our assessment, but actually that's probably been covered earlier on rather than the end of life part. Would you agree with that, Alex?
Yes, although actually was having a discussion about funding of care only on Thursday, I think it was, for somebody in hospice care, and actually it was about potentially moving that individual from hospice care to placement. And actually somebody said, well, hold on one second, surely they would probably get what's called the fast track continuing healthcare assessment, which is available to people with a terminal condition. But the conditions of that are that actually that person, we have to document that they may die within 6 months, and actually that's not necessarily possible. So actually that's just an extension of those financial discussions. But yes, finances do need to be thought about. They do actually. Even if it's not from a personal financial perspective, it's actually ultimately from a placement or from other issues. The other thing here is that, you know, if I wanted a particular piece of equipment for somebody, you know, again, sometimes I find myself in a bit of a wrangle with the local equipment providers as to how quickly that can come. I mean, there are obviously, we do have some systems that are set up, and it does say, you know, actually is this palliative, and the delivery might be a lot quicker. But actually, if it's a complex bit of kit, then there's some clinical reasoning to put forward, and then it might have to go to a panel. So actually, again, very important, I guess, if we're talking about band 5s out there and other healthcare professionals, is actually stating within your reasoning why you need it and why you need it quick. Which is why we're having all of these discussions.
Yeah, thank you. Okay, so care planning and goal planning and care planning. So this is very much what's important for the person. What are their goals? And it is very personal to that individual. So we go back to quality of life. What essentially is important for the person you're working with, and then working with that. And actually you might have to then work with other professionals to help that happen. So I've worked with a young lady. She had juvenile Huntington's disease, and one of the things that she wanted to do was go and see a concert, and actually for her, I can't remember who it was now, who she wanted to go and see, but to physically go and see a big show for her was too much. But we broke it down, and actually we managed to get her to a local event in the local community, which meant that it was for her planning her food, planning her tolerance to sitting in a wheelchair, and planning that journey. So for her, it was just a 15-minute journey to a local area. We knew there was a wheelchair stage, which was wheelchair accessible, and we knew that we could get the minibus quite close. So we're thinking about her and we're thinking about the family. And I remember doing a risk assessment on the day of her being at this concert and thinking, yeah, you know what, we've got enough staff here, we're going to get her up out of her wheelchair and we're going to have a little dance and then get her back in a wheelchair. And actually that felt really positive. And actually seeing her face and the members of staff, it was a really positive experience for everyone involved. And that was something that she wanted to do. So we went with her goal, but we had to actually do our risk assessment, is what I'm saying, and work with everyone else in the team, get the staff coming in off, yeah, it was an evening performance, so staff coming in their own time, changing shifts, speaking to speech and language therapist, and what can we take, what can she drink when we're there, a note for folks, making drinks, fizzy drinks with thickener, mixing them up. They go everywhere, whether it's Coke or a beer. You were thinking about her dysphagic needs and taking everything that we needed for that. So what's important for the individual? Coordinating care as well. I'm just trying to think of examples that I've certainly, for me, when you talk about equipment, Alex, yes, a deep breath, trying to get equipment even into a care home setting. Who's going to pay for it? We need it, and getting it timely as well. So for me, a lot of time can be spent behind the scenes, actually trying to work with reps, getting the right equipment and getting the funding for the equipment and getting it authorized and getting it in for the individual. I suspect you're coordinating with more multi agencies compared to me working in hospital setting, Alex.
Yes, yeah, and like you say, where the lines of responsibility go and finish, and just so many different things. Yeah, the background paper shuffling that goes on, that's a huge part of our job. Yeah, but it's worth it, and it's really nice because Tracy actually put a note about your example about Bravo. What a terrific outcome for your young lady. So yeah, thumbs up. Brilliant. Thank you, Tracy.
So that's why I was hesitating a bit. The last part of the OT process is delivery of care, and yeah, at late stage, I would definitely be looking at moving and handling. Potentially, we've got people who are bed bound, or it's uncomfortable to come out of bed. So we're hoisting. How are we doing that? Use of slide sheets, single handling, or two carers now to handle. Managing posture. So I've just described managing posture in seating or in bed. Alex was talking earlier about managing posture on the sofa and how we get the best posture. So I smile because we talk about risk, and we really, I guess I want to get across, it's reducing risk. We can't always prevent risk, and it's doing that sometimes dynamic risk assessment, which was what I was doing in the community on that day. On the ward, I wouldn't have been recommending that we get this lady up in standing, but actually that moment when she was at her most alert and we had the staff around, we took that risk. But we can't always prevent all the risks. It's very much reducing, and that's really hard, as you said, Alex. A new qualified OT coming out and having to do that risk.
That was something that we wanted to mention, wasn't it? Actually,
that risk assessment.
Yeah. That actually you get taught something in university or on your placement, which is very much about you must do it in this particular way, but actually, when it comes to it, actually it can often be very, very different experience, and it has to be the balance of risk versus the balance of benefits versus the dynamism that you say that goes on, and actually because we're talking about palliative and end-of-life care, actually, hold on one second, actually, is this what this person wants, and can we facilitate that? So yeah, absolutely. Herwig Langer, presume, apologise if I've not pronounced that right in the chat, has said there should be funds for immediate delivery of helpful equipment. So what we're saying actually is there are processes available to us where we can get statutory equipment to people very, very quickly. We can do, but sometimes I guess what Kirsty and I are saying is that sometimes with HD, sometimes the statutory kit doesn't work, and then we have to make additional reasoning to get additional bits of kit to people. That's what we're talking about. So statutory kit, basic kit does exist, but sometimes we have to make an additional requests for other kit. I hope that makes sense.
Yeah, and that process generally takes longer. I know, for example, if I want something above and beyond, I quite often need to get 3 different quotes so that I can and I have to justify, once I've got those quotes, why that piece of equipment is the piece of equipment that's right for that person. And then you're really stuck when you find that actually you can't get 3 quotes because it's so specialist. And then it's for us as OTs, we're on paper, we're putting the pros and the cons, and I think if we can clearly document the benefits of something, and then the risks if we don't have it, and document how we're currently managing the risks, but what the concerns still are.
Yeah, I was going to say, often what I do in my reports is I don't quite say it, but I do say, if you don't provide this equipment, this and this and this will happen. And therefore, if you like, sort of put the onus back onto them. And I think we've spoken previously, haven't we, about seating. Actually, I've sometimes said, actually, what are the safeguardings here that are going to come out of this if this doesn't happen? And I don't want to be speaking about that when I'm talking about palliative of an end of life, but sometimes I have to do that. And I guess, again, talking to our less experienced colleagues out there, I would say that sometimes you have to go that way, and you have to be quite knowledgeable about some of the legislation. Yeah, sometimes you just don't know where to start. So HDA, thank you very much, you're fabulous. Your local advisor, and their fact sheets and their webinars, particularly Kath Lyon's webinar.
Yeah.
GPs, yes, I know that they're like gold dust, but actually, like we said, they will be the hub of the gold standard framework, and may actually be registered with it, and may actually have weekly or even monthly meetings with palliative care teams and local care teams about the coordination of palliative and end-of-life care. I've said your local team, that sounds a little bit, okay, your local team. So hopefully as a person with HD, as a family member, as a healthcare professional, you'll be able to go to members of your local team and say, what do you do if? If you can't, I suggest that you go to your palliative team or your local hospice, and they're an amazing source of information. And even if you're just going and you're actually asking for some training, they usually run some fabulous training. They've run fabulous trainings on difficult conversations, all kinds of things. They run a lot of webinars now and a lot of virtual and e-learning courses, but sometimes actually you just want to talk to somebody about this stuff. Do have a look at the gold standard framework on the interweb. Just type in gold standard framework end of life and it'll come up. And again, there's lots of learning that can come from that, lots of links. For planning, okay, for up-to-date planning advice, I recommend an organisation called Compassion in Dying. Again, please look it up on the internet. Like I say, they have emails, or they do have a telephone advice line, and they have templates for all of these documents, which you can then lodge with your local GP. But you will have to speak to your local GP about what's called the respect form, which is the centralised form that's lodged with them about your wishes and feelings and values and advanced planning. And then we've spoken about Catherine Mannix. Have a look at the BBC Ideas website, where she does the short film on what death feels like, because often, again, it's about us and we worry about how that might feel for our loved one, and it actually breaks it down. And then there's this other film which is called Should Everyone Have an End of Life Plan? And it's an argument from both sides, because as we've heard today, some people don't want to talk about it, and that's fine, but some people do. And for some people, it's not even about dying in and of itself or death in and of itself. It's about, actually, I want chocolate ice cream at the end of my life, and I want to be wearing my favorite dress. So it's about those types of things. We wanted to end with this: who looks after you? This is not an easy subject, but it's interesting. It might not be an easy subject here, and maybe it's not an easy subject throughout the world, but it is looked at differently. But you must make sure that you've got somebody holding your hand. Please do reach out. We wanted to share, I suppose we wanted to end up with something positive, didn't we, Kirsty? Because we wanted to talk about a visit that we did to the Netherlands a couple of years ago. And over there, the healthcare system is completely different for people with Huntington's disease. As soon as you get your diagnosis, the government funds your care from that point on, so there's no jumping through hoops. But what was really, really interesting was we were getting quite het up about all of the conversations, and our Dutch colleagues were like, why? And it's because actually culturally over there, and I think I've said this on the webinar previously, they'll quite happily talk about sex, drugs, rock and roll and money. They also talk about end of life. They also talk about choices in death as well, and having a right to euthanasia, for example. And for us, it was a really positive experience. It was a really incredible way to look at the world. And we kind of wanted to leave you with that it is possible. It is possible by talking about it, that it doesn't hasten it, and that it can make it easier. And we just need to get better at it, really.
I know when I was speaking to, I'm not sure she was from Holland, but a young lady who had the HD gene in her family, and she knew that she was carrying, and for her to be able to talk about what her life looks like now and in the future, she described it as it giving her hope. And that really touched me, the fact that she was living with this disease, a family member, and knew herself that she was positive, but she was so positive that she knew herself that she was carrying the gene, but she was such a positive, inspirational young girl. And for her to be able to talk about the end stages so early gave her hope and gave her choice, and that was just amazing. Thank you.
Yeah, Rachel's just put on the chat a great training resource for health professionals on talking about end of life, realtalktraining.co.uk. And it is fabulous, Rachel. It's based on conversational analysis of actual conversations around end of life. It's really worth looking at, really worth looking at. But yeah, I mean, I agree with you. I mean, the first time that I ever spoke with somebody about their approaching end of life with somebody with MND, and I genuinely was petrified. But actually, even though she raged and she bawled and she told me to naff off, more than that, in many places, latterly she said to me, actually, it was a great conversation. And I helped her start to take control. So I know it's not like that for everyone, but I would encourage it. That, I think.
Thank you both.
Is it?
Thank you for the webinar, but also as we come to the end of a series of 11 webinars. Wow. Just thank you for the whole lot as well. I think I'm sure you both will be back. But yeah, just want to take this chance to say thank you.